They enter the cabinet and they have to be converted to the self-benefit of the drug, and that takes days. So if there's a patient who's bad hardware, it's going to take days to get that thing under control. Plus, there is a suboptimal response in up to 40%. And there's a subset of patients, a significant subset of patients, who have polymorphisms in the cytochrome that is responsible for the metabolism of PPIs, the CYP2C19. And if you've got the wrong polymorphism, you're not going to respond very well. So enter the PCABs, okay? This was a molecule that was discovered in Japan by a company called Takeda. And unlike PPIs, which irreversibly block the proton pump down the line, but are very vulnerable to acid exposure because they get destroyed by acid, interestingly this is acid stable, so it doesn't get attacked by the acid. And it goes directly to the ATPase, the potassium channel. And vonoprazan was the first of these molecules to be described, and it was licensed in Japan 10 years ago. So we're way behind Japan in this use. And you can see that the mechanism of action is very potent. Because of its acid stability, you can see that this blue thing represents vonoprazan, and the H+ here is in red. You can see that vis-a-vis the lansoprazole, which is like throwing a huge amount of infant troops, that is what happens when you use a PPI. Most of it dies in the heat of battle through acid. So vonoprazan is bulletproof to that. And it's really, really good, and it competitively blocks, so it's not going to permanently block that, so it's going to be relatively tachyphylaxis free. You don't have to increase the dose to get the same effect. Because it is not a prodrug, it works almost immediately. Many a time, once daily dosing is effective, and for Helicobacter eradication, it is usually used twice a day. And what about the pH control? Well, we know that proton pump inhibitors don't act immediately, and if you look at the pH on day 1, that is over 4, being more alkaline, with PPIs, we are really getting 23%. And at day 7, PPIs are still trying to catch up to alkalinize that stomach, whereas vonoprazan happens with birth. So nocturnal acid control is very important, and vonoprazan wins here. What about the clinical outcomes? The time that is spent with the pH over 4 with vonoprazan is much higher. And this is particularly important when it comes to Helicobacter pylori eradication. The cornerstone study, which looked at healing of severe esophagitis, and this is a study called Falcon EE, erosive esophagitis, and it looked at as a comparison between PPIs and vonoprazan, looking at healing, and it trumped it. 93% versus 85% when compared to lansoprazole, and it is much more effective if you've got severe esophagitis, which is where you need it. We needed an Air Force that was going to hit that severe esophagitis because that's where PPIs suffer most. And as you see, healing with LA, Los Angeles classification grade C and D, was 70% versus 53% in 2 weeks. Unbelievable. Very good. Symptomatically, patients were even better with vonoprazan, and they had major relief of heartburn even early on in the weeks of therapy. So this study has shown, and other studies in Asia have shown, that it is most beneficial with severe esophagitis and also to affect symptoms. there was not much of a difference in terms of mild. So we can use cheaper agents such as the PPIs in mild disease. And the maintenance and it was the PPIs here. And at long-term follow-up, again, there was avoidance of tachyphylaxis. Remember that when you are on a proton pump inhibitor over time, it gets less effective because of tachyphylaxis. And in special situations, such as those patients who have systemic sclerosis and other things that promote reflux, it was also cost effectiveness. You have to factor in what we are avoiding here. We're avoiding those unnecessary. We're avoiding those visits to the hospital. We're avoiding consultations. So it wins overall, again, in cost effectiveness. But what about non-erosive disease? Is it helpful here? Non-erosive disease is a heterogeneous cohort which is shown to actually be helpful, especially if you always think about the safe allergen as an add-on. So, yes, it was better than placebo, and yes, it makes a difference even at low dose. And you can even look at on-demand, although the data is still accruing here. You don't have to have your patients taking the drug all the time. You can have on-demand use. What about refractory heartburn? You see these in clinic every day. Yes, there is an added advantage because of the potent acid suppression, and in these patients, of course, always retain that alginate as an adjunct. Vonoprazan for Helicobacter. To suppress the acid production and raise the pH, you are allowing your antibiotics to work better. And this has allowed us to look at regimens that try to shimmy around the clarithromycin resistance that is increasing worldwide. Shorter courses with single antibiotic, amoxicillin high dose, and vonoprazan alone. And so far, the studies have been very, very encouraging and not always widely available. So to answer your question, Professor Ibrahim, is vonoprazan a game changer in acid suppression? Well, the answer is yes. Yes, because it is faster and more potent in acid control, and clinically it is practice-changing, especially in severe disease and Helicobacter pylori eradication. In mild GERD and NERD, the benefits are implemented but must be weighed against the cost, and overall it's going to be a valuable adjunct to our toolbox. I thank my dear team, and I invite you to come to more